Michelle Staples Horne has been a friend of mine and a colleague and a valued companion from time to time, even here in Hawaii. Um, uh, Everybody mute, or I'll mute you for you, but please mute. We've known one another at least 25 years, more like 30, I'll bet, Michelle. And
yeah, I think so.
my first National Commission and ACCP meeting was in San Antonio. And it's been a while since we met in San Antonio in the fall at the NCCHC and the ACCP meetings. And she's been doing juvenile corrections for that long. We really hit it off partly because that juvenile corrections was where I got my start in corrections, and I really loved working with the juveniles when I did. And she's a member of the ACCP for as long as that, and has been awarded very appropriately the Armin Start Award for excellence in the ACCP's highest accolades, and just about every accolade in correctional medicine. I'm going to go ahead and say offhand, and with good reason. So I'm not going to belabor your introduction, Michelle. Go ahead.
No, it's fine. We'll go ahead and get
Thank you for showing up. And again, Jeff will be talking in January, and all of these sessions are able to be accessed through the recordings, and your emails now have that information in them about how to access the recorded sessions so that you can spread that word to your colleagues and friends as well. Without further ado, go ahead, Michelle. I'm
Thank
looking
you,
forward to
Mike.
this myself. Why don't you go to slideshow on your?
I sure will. I've got it. As you should be able to see the big care and treatment. Can you see it? Your screen is paused.
We're seeing the blank slide is what we're seeing right now.
Why is it paused? Oh, I see. That's terrible. Okay, hold on. Let me do resume share and see if that does it. Okay, now hold on. Let me go to slideshow. I didn't realize it hadn't, because it was showing me something different.
They might want you to go enable editing. I'm not sure, but
you screen sharing. Oh, protected view. Hold on. Let me
you're definitely sharing right now.
Oops,
it lost you though.
Now it went away. Hold on. Windows closed. Okay, let me try to do this one more time. Hold on a second.
If you want, I'll put it up.
I'm gonna try one more time. Here we go.
Okay.
Share. Okay, and we're going to do slideshow.
You should be all set.
Slideshow from beginning. Okay, can you see it now?
We're doing great. There we go.
All right.
Thank you.
Okay, thanks everybody for joining us today. And I'm going to move pretty quickly because I've got a lot of information to cover. If you would just include your questions in the chat and we'll be able to capture them. I want to make sure I get through everything. So if you would please put that your questions in the chat. So I'm going to talk about care and treatment of youth in correctional settings. These are our learning objectives. Really talk about specifically the population that's served and their specific health needs, list effective screening and treatment guidelines, and recognize the medical and legal implications of determining the utilization of health care for youth in correctional settings, and finally discuss opportunities for careers and advocacy in correctional health care. So this is, I had to pull up a sort of older slide because we didn't plan to do this until what, day before yesterday, Mike? So these numbers might be a little old. So in 2021, the ACLU gave figures of 60,000 kids under 18 on any given day and 1,909 arrested each day by the according to the Children's Defense Fund. So when we talk about kids and juveniles, let's talk about the population in general. And this is going to be a quick review that you probably not had since medical school. When we talk about adolescents in the various stages of development, they have special considerations for medical programs. You have to modify treatment protocols and medications most times because of their age and sometimes size, because we cover kids from age 10 all the way up to age 21. So it just depends on the age group that you're dealing with, but it's very diverse within juvenile corrections. And privacy and confidentiality really can sometimes be more of a concern to youth, even though they will disclose everything to everybody else. They don't want you to disclose anything. So I'm going to quickly run through the stages of adolescence, with the first being the early stage, age 10 to 14, where they have those growth spurts, begin the sexual maturation, increase interest in sexual anatomy, anxieties and questions about size of genitals begins, and self-exploration and evaluation. Then we move on to, hold on, I'm frozen with my slides. Hold on, let's see what happens here. Oh, that's interesting. Okay, so why are my slides not moving? Like, oh, there we go. Okay, middle stages, stronger. Okay, so I've got a spirit working in the computer here or something, but these are the middle stages, the characteristics of the middle stages of adolescence, age 15 to 17. And this is where the majority of our population sits in this age category. They relate more strongly to peer groups, have a little bit more reflective thought, but they're really transitioning between this dependence and independence. And this is a stage where sometimes they can act like an adult, but sometimes act like a kid, and you never know which one you're going to get that day. And then finally, the late stages of adolescence for 18 and above, where the body really fills out, takes an adult form. You have a distinct identity, ideas and opinions become more settled, focus on intimacy and formation of stable relationships and plans for future and commitments. Now, remember, even though that's a late stage of adolescence, the brain is not completely developed, particularly among male adolescents, until really, I would say, age 26. So you still have some development for those kids in that later age group. So for the most part, adolescents are not healthy, resilient, independent. They are, healthy, resilient, and independent yet vulnerable, but they're not big children or little adults, and they have special needs. So when we talk about the culture, they're very peer dependent. Everything is about them. They're very egocentric, since they have the selfies on the cell phones, those things. They have these distinct language and dress, which we can't keep up with because they change it from day to day. They have popular culture influence, as you can see by all the social media and every other type of media, how they influence that, and an ongoing search for identity. So these are things that are really shaping adolescence: the race, ethnicity, religion, socioeconomic status, family, and peers. Now, you have to put all of this in context, because our kids have a little bit of a different story. If you see to the right, where most of us grew up, or when most of us grew up, we may have experienced birthday parties, baseball games, good school experiences. However, a lot of our kids that are within the juvenile justice system have a history of trauma, traumatic brain injury, PTSD. They've experienced physical, sexual, and emotional abuse, substance abuse, exposure to criminal behaviors, sometimes by the parents or the caregivers, parental instability, negative environmental factors, and some developmental disabilities. So you see, they're growing up during their adolescence can be quite different than what we may have experienced. And that's why oftentimes they're involved in the juvenile justice system. So if you look at different legal requirements of youth in custody, it really depends on two things: age and the law. And the laws are different depending on where you are. The age is different depending on where you are, because the age, there's an age of adult determination, which may be based on a specific age, like 18 in some states, or it may be related to a court order that makes the kid independent or emancipated at a younger age. but there's a specific age that you can consent for services and treatment. And then the age has an impact on correctional environments, because if you are housing young people below the age of adulthood legally, then they cannot be housed with adults, and you have to provide sight and sound separation. And then the laws for young people in custody, there are different sentencing requirements. Sometimes they can be charged as adults. Sometimes they're charged as juveniles, and there are different requirements. Most time when the youth are charged as an adolescent or a juvenile, those charges disappear or get expunged when they're age of adulthood. You have varying parental custody and involvement based on the age. Certainly school requirements in each state, and the requirements to provide special education and special health needs. So minors, even though they may be less than the age or legal age, they still have a right to confidential health services relating to sexually transmitted infections, substance use treatment, and pregnancy. And those are without parental consent. So you have to get consent to discuss those things with the parent, even though the child may be a minor. Another big issue, which I think we have addressed and had a statement, a position statement very early on with ACCP, was regarding the use of mechanical restraints, including during pregnancy. And those have been prohibited, I believe, in most states now. And that is not a practice that we want to have continued. Access to health records, depending on, again, sometimes things have to be redacted, like STI information, even though the parents may ask to see the medical record. The use of chemical restraints and forced medication, there are a lot more requirements and issues around that. And the big one is restrictive housing in this population, because we know teens and young people do not do well with being isolated. And if they particularly have a mental health condition, it can be exacerbated under those circumstances. We all know that healthcare is a legal right via Estelle v. Gamble in 76, and that we don't want to show deliberate indifference for their care and treatment. So healthcare is a constitutional requirement. And so they really require these specialized services appropriate for the age and developmental stage. And these health services must meet the community standard of care. Well, how do you know what the community standard of care is? Well, you follow the AAP, the American Academy of Pediatrics guidelines. I think I have a Bright Futures slide in here further. But certainly it's different from jurisdiction to jurisdiction, because some juvenile justice systems are a freestanding state agency. Some may be a part of Department of Corrections. Some may be with Family and Children's Services. Some have private vendors operating them. Some are state operated facilities. So it's a lot of variation, much more variation in juvenile systems than it is in adult systems. There are non-secure placements, such as wilderness programs. These are all diversion programs to keep kids from getting locked up. And depending on what state you're in, you may have jurisdiction over those kids, like we do in Georgia as well. So we have the youth that are in non-secure placements that we're in charge of, as well as those in secure settings. And you have youth detention centers, which are like jails for adults, youth development campuses, which are like prisons for adults. And then you may have, in some jurisdictions, kids that are housed in adult jails or prisons. And those, again, have to be separated by sight and sound. So in secure facility populations, there's an overrepresentation of minorities. It's predominantly male. The average age is 15, but now most of them are there for more serious offenses, since a lot of juvenile justice reform has occurred. And in a lot of states, they have totally closed. Some states have completely closed those long-term secure facilities and are serving kids completely in the community. So a lot of reform has been done on juvenile justice, and a lot of the laws have been changed and amended so that we try to keep kids out of locked settings unless they have more serious offenses. So why do we really need to focus on adolescent health? We really want to reduce the death, including suicide and preventable diseases, because this is a high-risk population. Even though they may not have diseases right now, we know that the potential is there for them to contract hepatitis and HIV and the other things that if we don't make an intervention, they may lead to those behaviors that lead to those diseases. And we really want to fulfill the rights of adolescents to health care and help them learn how to navigate the system, because ultimately they will be back in the community and should know how to navigate the healthcare system. And we know that they're at risk for adverse health outcomes because of substance abuse, violence, sex, meaning pregnancy, STIs, HIV. Poor dietary and dental habits are, hold on a second, are very much prominent in this population, as well as lack of physical activity. A lot of that is because the areas that they live in may not be safe to go outside and play like we used to maybe a couple of generations ago. Their most common health problems are really two things. The biggest one is dental care or lack of dental care. That's the number one need when they come into us, because most of them have not seen a dentist since they were 5 years of age, when it was time to go into school and they got that initial screening. The second largest health problem is mental health disorders, and then substance use and abuse. And then we have, of course, high-risk behaviors for STIs, and they have a lot of injuries. They can either be self-inflicted or due to just youthful or aggressive behavior. Youthful behavior of things like climbing up on top of the basketball goal and deciding they want to jump off to see what happens, or aggressive behavior with them fighting with one another. So those are the really most common health problems. Every now and then we'll get a really serious new diagnosis like a leukemia, a thrombocytopenia, or something that may not have been diagnosed had they not been, in that case, fortunate enough to be detained, that we did the screening and discovered that there was a more serious medical need. So they have a lot of barriers to healthcare. I talked a lot about this, their concern about confidentiality, and a lot around parental consent and notification. Yeah, poor communication by providers sometimes, because it takes a different person to be able to connect with adolescents, and they can't be insensitive. There's there can be a lack of medical autonomy or a medical home in the community. A lot of these kids have not been seen by anybody until they come into the facility. And oftentimes they identify us as their primary care provider, because they don't see anyone else unless there's a trauma involved or they go to the emergency room. And I don't know if you all know, you probably do because it's similar with adult populations, but a lot of our kids are eligible for Medicaid. And so that gets discontinued when they are incarcerated with us. And then we have to work very hard, used to have to work very hard to get it reestablished, but we have come up with a mechanism now that makes the process a little bit shorter once they get released, to get them back on Medicaid or also for private insurance coverage. And then, of course, the big one is transportation. If you live in a more rural state like we are in Georgia, it's hard for kids to get around to get to appointments once they get released. So I mentioned again the community standard of care. You have to have unimpeded access to care. You cannot schedule sick call during recreation, or guess what will happen? The kids will go to rec instead of coming, even though they may be deathly ill. I believe personally that co-pays for medical services for kids is a barrier, and so we do not require any copay for young people. We certainly need to make certain that we are PREA compliant and that we are compliant with ACA and NCCHC standards. Here's our Bright Futures screen. So the American Academy of Pediatrics actually gives you certain preventive and measures and priorities for screening in this population. They're specific to each age category. And we have a set that's specifically for age 11 to 21, and that's available online. So some of the recommendations include physical growth and development, monitoring social and academic competence, emotional well-being, risk reduction, injury and violence prevention. And so what I've done is incorporated all of those into our medical program to make certain that we are following the community standard of care. So we start out with a health screening and appraisal that's done within 2 hours of arrival. We do not have 24-hour nursing care, so the nurses train the custody staff to do this check mark appraisal, and it's set in 3 columns so that if you answer the specific question and it gets checked a yes or no, it ends up in a column or not. And if it ends up in the column where there's, say, no medical problems, those kids go to general population. If there's a questionable column, then those are held over until the nurse arrives the next day to evaluate. And then if it's a more imminent problem, bleeding, loss of consciousness, et cetera, those kids go out. So within, and we do a medical, dental, and mental health screening when they come in. We do a complete nurse health appraisal, which is a review of systems within 24 hours, and then the PREA screening. And we also include LGBTQ and sexual assault screenings because we want to be considerate of a kid's gender preference. And so that's asked from the beginning, and we will provide clothing appropriate to the youth's stated gender and the request for names, et cetera. These are some of the screenings that we do. Growth charts, we do a lot of blood pressure, vision, and hearing. You'd be surprised how many kids need glasses. We provide those. We do the scoliosis screening, which is required for school in this age group. Tanner screening. We used to do PAPS, but now the requirement has been changed and it's no longer recommended in our age group. And then we do that history of abuse, and we also report to Child Protective Services whenever we get a positive history of abuse. Physical exams within 3 to 7 days of admission. The standards usually say 7 days, but I require 3 days, 3-day physical if the child is on medication or has a chronic medical condition. We operate chronic care clinics and have very time-limited, unimpeded access to sick call using the nursing protocols and then all of the ancillary services that you see there. Laboratory, we do everything. Cholesterol, we'll even do, even though it's not necessarily recommended or required in this age group, we'll do a one-time hepatitis C screening because we know our young people like to self-tattoo with shared needles, et cetera. And so we will do that. Allergy testing is something that we do because we have a lot of kids that claim to have specific food allergies, and oftentimes it may be related to some gang food preference or disallowance. And so we do specific allergy testing and have dietitians to provide the allergy test, the special diets based on the allergy testing and the history received from the parent and the kid. This is one of our exam rooms, and you would know that you were in a correctional facility when you looked at this. So we have a full ambulatory clinic in each facility, a dental operatory, either on site or a mobile unit that we use, and we're fully staffed and everybody's fully licensed and credentialed. And even though we don't have a person on staff 24 hours, they do have on-call access to staff with relationships with all the local emergency rooms. We also have community health resources, such as OB specialists for pregnancy. We have public or government providers, such as public health departments and community health centers that partner with us. And not as much now. We have to get back going because of COVID. We used to have a lot of university public health, medical, and nursing school programs participate with us, but that sort of went by the wayside with COVID. So we're working to try to get those back up and running. Health records documentation, we're all HIPAA compliant, and we have guidelines for release and transfer of medical information. We were fortunate enough to develop our own electronic health record called the Juvenile Tracking System back in 1998. So since that time, I've been able to look at each child's medical record on my computer, and we have, of course, have restricted access to that, but it helps with transfer and movement of kids to different facilities. Because I forgot to tell you, we got 25 facilities in the state, and an ADP across those 25 facilities of 1,000 kids. So you've got a lot of movement going on, and has always been that way. In fact, when we developed the system in 98, we had 3,000 ADP. So it's really been important to be able to follow these kids with JTS, so we're not duplicating services or overlooking anything. You all know this, in correctional facilities, high alert on infection control. I mentioned the dental care, medications. We do not do any KOP, and I wouldn't recommend any KOP in any juvenile settings. So everything is direct observed therapy with medications, because kids are just very creative. I'll give you one quick story. We used to allow the kids to keep contact lenses for vision correction. And we found out in the girls' unit, they were all sharing the contact lenses. Everybody was going to everybody's eyes, and then somebody drank the solution. So we had to stop the contact lenses, excuse me, and we get glasses for everybody now. Substance use and behavioral health, of course, are highlighted. And then let's just talk a little bit about the infection control program. Let me see. Yeah, we're doing good for time. I'm sort of losing my voice, sorry. We have a facility environmental sanitation practice. We do not, the kids help with some of the sanitation in the facility, but what we were finding is a lot of times the supervision may not have been what it needed to be, and kids were drinking cleaning solutions, et cetera, and having to be taken out for emergency assessment. So what we did as a part of a project that we did to look at cost reductions, we switched to a product that was non-toxic. So if they drank that, they didn't have to go out to the emergency room. So we've got that whole product within all the facilities that's non-toxic, and that has helped significantly, and still does just as good a job with cleaning and meets all the EPA requirements for cleaning. We do tuberculosis screening for youth and staff, and we use quantiferon for both. Screening for respiratory and skin infections, flu shots, MRSA control, licensed scabies control, food service inspections by our own internal staff, and as well as accounting food inspectors. We've got our kitchen staff ServSafe certified. We do all the STI screenings. We provide all immunizations, and that's through a program called Vaccines for Children, where the federal government gives vaccine to the state public health, and state public health gives them to us for free. And our only requirement is that we put those into our immunization database, which is appropriately named for Georgia GRITS, the Georgia Registry for Immunization Transaction Services. So we put all our information in GRITS, and then when the kid gets their immunization in our facility, they can go back to the community, and that community provider can see that they need, say, another hepatitis vaccine, Hep B vaccine, but they can't see that they got it in the Georgia Department of Juvenile Justice, because within the grid system, it only lists the provider's name. And our providers work both inside and outside of our setting. We do all of our infectious disease reporting for public health. And man, when COVID hit, that's a whole nother report I could do for what we did with COVID. And so we functioned as a closed point of distribution for biohazardous agent release. If there was a mass terroristic threat where we had to get antidotes at, then we would assist with that. And I'm not in COVID, man. We did a lot with COVID. Fortunately, we had a pandemic response plan, excuse me, initially. But when COVID hit, we really had to bump that up and do a lot more with departmental policies, screening and testing, isolation, quarantine, the whole 9 yards with the pandemic, transfer and release, notification, and tracking. And again, that's a whole topic in itself. I talked already about the vaccines for children participation, and we give everything. The only thing that's not on VFC right now is COVID, and that may be coming soon. We do a lot of screening for chlamydia, gonorrhea. When I mentioned we do the one-time Hep C, and then HIV is done as well. We have very few kids that test positive for HIV, but we know that the risk factors are there. So we try to do interventions with them and provide health education to prevent them from getting infected down the road. We again provide the community standard of dental care for children, and we do everything except braces. So we don't just snatch teeth out, we do the fillings and crowns and all those things, and cleanings every 6 months, and dental education, and a lot of restorative dentistry, flippers when kids get their teeth knocked out with us. So I make sure they go back home looking the same way. I talked a little bit about medication management earlier with all the inventory control measures. Certain medications are contraindicated in this population. And then some of them are allowed in this population, like meds to treat ADHD that are not necessarily, stimulants that are not necessarily allowed in adults, because remember, they're in school. We have a formulary that we just updated. Oops, hold on. That we just updated, and we have access to newer psychiatric drugs because we know we have a heavy number of kids. About 40 to 60% of our kids have a mental health diagnosis. So we want to work very closely to prevent any suicides. They often have problems with sleep when they come in, and a lot of that's due to just having a schedule that they may not have had when they were out. We have PBIS, a positive behavior incentive programs. Kids have access to counseling. We have psychologists, psychiatrists, master's level counselors, as well as counselors that assist on the security side. And of course, substance abuse treatment is provided long-term in some of the long-term facilities, and we do interventions in the short-term facilities. Psychodiagnostic examinations, everything is trauma-informed care and treatment that we have in our behavioral health program. And we also utilize telepsychiatry and have access to community mental health providers as well. Treatment teams meet regularly to discuss kids' medical and behavioral health problems. We also do team meetings for kids with special needs that have IEPs or special education that requires those meetings, and medical is a part of that as well. Dietary. We are very strict about what the kids eat. There is no commissary, so they can't get medications from commissary. They can't get Twinkies and honey buns and all those things from commissary, because I want to make sure they have a healthy diet. So I have 3 registered dietitians that will really, everybody eats the same thing across every facility. So it seems like a lot of food, but you got to think, if anybody's had teenagers, they love to eat all the time. So we provide breakfast. We provide a mid-morning snack, and we started doing that because we participated in the school lunch program for reimbursement. And when a few years back, they cut out the amount of fat that you could have in the breakfast meal to get reimbursed. And so it wasn't enough for the kids to stay full until lunchtime. So we have breakfast, a mid-morning snack, lunch, and after school snack. And during that after school snack, the teachers provide them with health education snippets. And then they have dinner, and then they have a bedtime snack. Lots of calories, but we're feeding everybody the same thing, and they may not eat it all, but what you don't want is a bigger kid taking food from a smaller kid because they're still hungry. We have lots of fresh fruits and vegetables, low-fat milk. There's no coffee or tea, reduced fat and sodium. And I talked a little bit already about the food allergies being identified in the special diets. And here you go with the resources, excuse me, for the American Heart Association and the Choose My Plate. We provide 1 hour of daily large muscle activity. And we do, in addition to that, they're in school, so they also have PE in the school curriculum. And then we really want to emphasize the exercise for these kids because they may not have had the opportunity to exercise before. And we want to encourage other activities other than basketball. I really personally want to eliminate basketball because of all the orthopedic injuries, but I came to a compromise with the security folks and administration because they got better sneakers for the kids. They used to try to play basketball in flip-flops. So we're down on ankle injuries, because of that. And then also we started a yoga program, and that has gone over very well with the kids because in addition to being physically challenging, it helps them with mindfulness as well. And then we have a lot of horseplay. I told you about the kid that jumped down off the basketball hoop. He really did, because he wanted his grandmother to come and visit him, and she was on the do not visit list. So he figured if he injured himself and got hospitalized, he could get her in to see him. So, that's just the way they think sometimes. But you got to really monitor them for their activities. And I talked a lot about, just while we're trying to teach them about their own health and basic health knowledge, to really modify some of these health risk behaviors that really will lead to really bad diseases. The thing that I'm most proud of is all the immunizations we've been able to give them, like the hepatitis B vaccine, that even if they unfortunately end up in the adult system, they will not have to deal with Hep B because they will have been fully immunized with us. Education, you can't say much about health without talking about the education of the kids as well. So we are a certified school district. We have so many kids. We're actually a district within the state, and we have certified teachers. And not only do we provide GEDs, but we give diplomas, provide vocational education, and provide online college courses as well. I mentioned about the special education IEPs, those special education plans. We participate in those. And then we also have a big health education program that includes a wellness program where they have these big events every year. They may have a health fair, or they may be physical fitness challenge or something that they do once a year. But in addition to that, we do the daily or the Monday through Friday health education sessions with them as well. So, it takes a village to do this, and certainly we want to get back to collaborating with the schools. But I'll talk a little bit about our reentry initiatives, because that has been a community collaboration that we've been able to continue even with COVID.
Something happened? Did she just disappear? Somebody help me out here. She gone?
She's gone. I don't see her anymore.
Okay, so my thing seemed to freeze mid-sentence there.
Correct.
So and
Me too.
I thought it was frozen, but just hang on. I'm gonna be in touch with her. Something happened on her end. This happens once in a while.
Been doing a good job.
And I don't see her. This is a first. We have a new first today. Everybody gets to witness.
She's
a new
joining now.
first. There we
I'm
go.
back. Sorry.
We're all good.
I don't know
We're
what
all good.
happened. It just died on me. Hold on, let me see if I can get the slides back up.
If you're
Let's
having
see.
any difficulty, turn your video on. But if you're having any difficulty, then I can always get mine going. You're toward the end of your
Okay.
you're toward the end of
Okay.
your
Yeah, I'm
slides
almost
anyway.
at the end. Yeah, I'm almost at the end. I am trying to get the share slide thing.
Why don't you just turn on your video and I'll put it up.
Okay. All right. Me.
I'm ready and
All right.
there it
Okay.
goes.
Okay. Good. Thank you. Okay, go back up to the collaboration slide. Couple of ones up. 1, 2, 3 up. Yeah, that's good. Thanks. Okay, we don't have but a couple of more slides left. I apologize. I don't know what this, hopefully this will hold out for now. But I want to talk a little bit about our reentry initiatives, because what we do when the kids are ready to leave the long-term facility, we will have meetings 90 days, 60 days, and 30 days out, and set up structures like for them to get back in school, for them to have positive peer groups like the boys club, meet with the parents, make sure the home situation is stable, that they have housing, that they have medical and mental health needs, some providers that have already lined up. So we try to do that in advance of being released, so that hopefully we give them the tools to be able to be successful in the community and not come back. We will also do things such as they have gang-related tattoos that are visible, then we pay to have those taken off by the dermatologist. And also we will find jobs for them. And we have a lot of good partners like Walmart, Home Depot, et cetera, that are assisting us with getting jobs for kids. Next slide. So we have program evaluation and quality improvement, of course. And so we have the external credentialing like ACA. Some of our facilities are ACA accredited. We've got about half done now. But we also have internal auditors that work under the commissioner's office. And then we have auditors that work with the Augusta University, our interagency partner. And so we want to make sure that we are evaluating and looking to see what's going on, because if you don't look, then you don't know and you can't fix. So next slide, please. And those are our credentialing organizations. Even though we don't have the NCCHC accreditation years ago, we just started with ACA, I was able to write our policies to meet the standards. And that way, if people are following policy, they're following the standards. Next slide. And then there's us, a plug for ACCP, because I can't remember which group I did this for. I think it might have been some residents or something. So I want to advocate for us and joining us under professionalism and advocacy. Next slide. I think that's the last one. Yep, I made it with 10 minutes to spare. So thanks everybody for your attention. That's my email address. if you have any questions, or I don't know if we had any in the chat, Mike, or if anybody has any questions, I'll respond to it now.
Great job, Michelle. Dr. Vore did a great job.
Thank you.
So I have a couple of questions, several questions, as a matter of fact. So can you comment a little bit on? I have experience in a major East Coast jail. They have a dozen people who are juveniles who are adjudicated as adults, but who live at the jail at the I won't say the jurisdiction, but at a large East Coast jail. And I wonder what you have to say about that, and how we can do a good job of taking care of people, because I think that many of the people in the ACCP are sort of stuck in that same situation where they have juveniles in their adult system. Makes it a lot more difficult.
Absolutely. And part of the issue is what jurisdiction you're in, how it states to those kids. Like for us, 17-year-olds don't have to be separated from the adults if they have certain offenses. So it depends on the state that you're in and the legal jurisdiction that you have as to how much separation is required. And then even if they're there, I think that it would be wise to look at providing education for them. Now, they may be beyond the requirements to go to school. Again, that's a thing that varies by state. I think you only required to go to school in Georgia until you, I want to say 15, maybe 16. So you're not required to go until you're 18. So that's another legal parameter that you have to look at. But things that if you were taking care of kids in an adult setting and you didn't have all the legal stuff that you could put them in with the adults, then you would want to, of course, keep them separated by sight and sound from the adults. You want to provide a different diet for the kids. They didn't need coffee and tea. They need milk and fruits and vegetables. You would need to provide immunizations for them that you may not be providing for adults. There'll be different medications because they may need Ritalin or ADHD meds, or or more psychotropic medications with fewer side effects. So there's a difference in the formulary that you may require for young people versus your older adults. And then they need more, well, I don't know, more, maybe dental care is a concern, but that's probably the same on the adult side. But what I don't like to see for kids on the adult side, sometimes they just do extractions. And I really don't like to see that for a young person. I would really like to see more restorative dentistry rather than, just extractions. So those are just a few things that you would need to look at, and certainly with your policies with recreation, the types of, access to therapies and behavioral health will be different for kids. Even group sessions would be different. So it would be a lot to do if you're really trying to take care of young people in an adult setting.
I'm sure there are other people with questions, so I'll shut up, but I've got other questions that came up too. So. No other questions from the audience? So I had a question about this whole release program that you've got going, and that's an awesome program. And you have a large population. You said somewhere close to 3,000?
Well,
It's
the
not-
original, yeah, we started out with 3,000, and then we went through the juvenile justice reform like the other states did. We were a little late, to be honest, because our juvenile code had not been revised in like 50 years. So we were late changing stuff. But when we finally did change it, it allowed the judges to provide services on the outside for kids without locking them up. We used to have a lot of what we call status offenders. So kids would get locked up for just misbehaving in school or skipping school or things that should not have made you get locked up for. So, or betting on a cockfight or something in South Georgia. So those changes allowed kids to be served in the community. So we're not locking up as many on those status. They don't lock up anybody on status, but the more minor offenses. So now our population is down to 1,000 a day, but that's spread across 25 facilities.
That was another question I had is, man, how do you train for all those little facilities? Because that's what I imagined was that you have a bunch of smaller facilities and the docks are not corrections docks. They don't,
Well,
maybe it's a good
interesting.
thing that they don't get corrections, you know, because,
Yeah.
you know, because that now they'll be treating more according to community standards, and in those smaller facilities, I mean, we know what you're supposed to do, but they don't
Yeah.
always know,
Yeah.
you know.
Well, the good thing, Mike, is that all these folks started way back with me about 30 years ago. A handful of new ones and the older ones teach them, and we still have trainings and all of that, but it's really the community piece that you mentioned. They're community pediatricians, community family practice folks that see the kids in that setting, and really, to be honest, a lot of them do it more as a mission because we don't pay that much. And so, and then those smaller facilities, we're heavily nurse operated, RN operated, and nurse practitioner operated, because in those smaller facilities, you don't have but 2 hours, like a 30-bed facility, I only have 2 hours of MD time a week, but I got a full-time nurse practitioner. So that's how we're able to operate with the and not, we don't have any full-time docs, so everybody is
Except you, yeah.
Well, now I'm part-time too now, but I used to be full-time. So pretty much everybody is part-time now, but it works okay because, like I said, we've got the nursing protocols, and to be honest, kids are relatively healthy, and if we stay on top of them, if our biggest challenge, to be honest, right now has been our correctional officer staffing and trying to keep the kids from fighting and doing the things that kids will do, a horse playing or injuring themselves. I get these reports because they always send me injury reports of anytime anybody injures themselves. And I had to chuckle at one because the officer was writing a report and said, officer so-and-so told you so-and-so to stop leaning back in the chair. You so-and-so continued to lean back in the chair, and then he fell backwards and hit his head, of course. And then that was an incident. But, the kids, they can still be kids. So that's been our biggest challenge.
How do you get custody to cooperate with this 30, 60, 90 day before release thing? That we wish we had something like that in for release in even in a jail or a prison. It's really hard to get anything like that going.
Listen, we got his policy. It's the agency policy. So everybody has to do it because it's policy. So we have a whole reentry team, including a reentry director. I'm actually sort of not, well, I'm chair of the physical and behavioral health reentry task force. So we have different, like somebody's over housing, somebody's over education. So we have all these different components. And so we have these reentry specialists that actually go to the locked facility and meet with the youth and the parent and find out what they need, and they go back in the community and make those connections. And so it works well because it is agency policy, and everyone, has to get on board and do it. So we've not had any problems with them cooperating. And then that's the other thing we started using. We used to try to get parents to come. Of course, all of our facilities in rural locations. So that's when we first started using the video conferencing. That was before COVID. And we increased parent participation by about 40% by doing that. And then once COVID hit, we're really able to continue that and then have more interaction with the kids on the video calls than the parents being able to come down to see them. So that's been one positive outcome of COVID.
Once again, does anybody else have a question? I feel like I'm having a one-on-one with you. We could have that anytime, but I'm also wanting to get some of this onto the recording, if I'm
Okay.
allowed.
Okay.
Anybody else? So my impression is that the ECT scores for juveniles who are incarcerated, that is early childhood trauma, is really high compared to the general population. And I'm also of the impression that you have a very extensive trauma-informed care system in the healthcare. Is that also a part of the philosophy or culture among the custody staff? And how do you make that happen? Anything that you can comment on ECT and trauma-informed care in juveniles facilities, I'd find that really helpful.
Yeah, we definitely attempt to provide all trauma-informed care. And I think, to be honest, it probably is a little bit more effective on the clinical side. We train the correctional officers and the other staff, but the difficulty that we have is with turnover. And as soon as we get someone trained and they come out, they start doing a good job, then another police department or, usually it's a police department will snatch them up because by then they're post-certified. And so we're having a lot of turnover, but we do train them. And we try to incorporate it into the culture. I remember I talked about the PBIS and the positive behavioral program that we have. So that's a part of that everyone tries to include and be more aware of the traumas that the kids have faced. So we are working toward that. It's not 100%, but we certainly understand that easily 100% of the kids probably have some form of trauma, if not multiple traumas.